for this conference series. I'm really happy to have Dr. Patel come talk to us about bowel obstruction ischemia. I think it's something that we see a lot in our co-management services when we see patients along with like the spine team or like the vascular team and whatnot. And it's great when we can collaborate like this and learn from each other. So I'm really excited to hear this talk. And so with that, I'm just going to hand it off to Dr. Patel.
All right, sounds good. Hi, everybody. My name's Keyur. I'm one of the new trauma ACS faculty. I work at Keck and County, so you may see me at both locations doing various roles, ICU, trauma, and then general surgery. I'm going to give a broad sort of talk on just different aspects of both bowel obstruction and bowel ischemia, again, because you guys see a lot of it, especially on the co-management services, but also hopefully to answer some questions, either diagnostic workup, when to call surgery, when is it relevant, when is it not relevant, and then hopefully answer some questions you guys have about some just vague processes, and then open up to any other questions you guys have. This is just an outline. We'll go over some brief anatomy. I know that's not everyone's cup of tea, but just some relevant points so that you guys understand where we're coming from. So we can have like a shared discussion about what's going on. We'll talk about obstructions, both small and large, functional and mechanical, and kind of maybe show you guys how we think about it and how we approach it. Same thing with ischemia. We'll talk about large versus small bowel ischemia and acute versus chronic. And then we'll end with just a little bit on pneumatosis, just because you guys do see that as well as its relevance. It's not comprehensive. There's other topics that I didn't include, such as intussusception and whatnot. And those are kind of case by case and not really highest of yield. They're just kind of like come as they are. But hopefully this answers at least a lot of the basic stuff related to bowel issues. So these are just two pictures just showing the arterial supply to the intestines. I know it's very busy, and I don't mean to get every single point down, but I just wanted to harp on a couple of things. We have three mesenteric vessels that feed all of our intestine: our celiac, our SMA, and our IMA, superior mesenteric artery, inferior mesenteric artery, and our celiac artery. There's a lot of collateral supply, especially with the celiac. And so even though we do see issues with embolus and or thrombosis, atherosclerotic changes over time, we don't really see issues with ischemia or stricturing or anything like that, usually with the proximal intestine that is fed by the celiac. Most of the talk will be concerning the small and large intestine. So the small intestine is mostly supplied by our SMA. And as you can see in the picture to the left, I don't know if you can see my cursor or not, but the SMA has all of these giant arcades of jejunal and ileal branches that supply our small intestine. So our small intestine is very well vascularized, and we don't really see problems in an acute sense if they're all the way down peripheral, right near where the intestine are. Our issues are when they're more proximal on the main superior mesenteric artery or any of these proximal branches, because as you can see, that cuts off the major blood supply to the intestine. And then we'll talk about venous drainage later as a separate topic. And then when we go over to the colon, we generally are supplied by three major colon arteries. So we have right, middle, and left. The left comes off the IMA, but our right, our middle, and including our ileocolic branches, those are all come off our SMA. There's a lot of variance that happens with the colon, but I wanted to point out the differences in the arcades between the small intestine, which are really robust and you have a lot of collateral blood supply to feed all the intestine, versus when you get problems with individual blood vessels with the colon, those are a little bit different and require us to often do interventions and or resections. And this difference in blood supply goes back to our surgical management of it, because we can do segmental bowel resections and put them back together because the blood supply is so robust. But when we talk about colon problems, you might say like, oh, it's a focal problem in just this little part of the colon. That often requires us to do a major resection. And you're thinking, why is that? And it's because if we don't have good blood supply to heal our new anastomosis, that will fall apart. So even though there's a small focal perforation or problem, it may require us to do a bigger resection so that we can ensure adequate blood supply to let the anastomosis heal. So when we approach these problems, they're two different beasts, and they kind of behave differently. And so I just wanted to keep in mind some of the basic anatomy related to small and large intestine. When we talk about obstruction, the first differentiation is small versus large. The small intestine is different than small bowel obstruction is different than a large bowel obstruction. And then, as you can imagine, because there are different problems and different managements, you can access it from above or below. Some of them are surgical emergency, some of them are not, and we'll talk about it. That's the first delineation. The second one is mechanical versus functional. So when we talk about mechanical problems, they're usually masses, strictures. You could have intraluminal obstruction from blood, like I said, intraluminal tumor, external compression, adhesions, any sort of volvulus or kinking of the intestine. So a physical blockage is, basic plumbing. If the pipe's blocked by something, generally mechanical, versus functional, where the intestine isn't working. And so if you look at the right, just kind of a little breakdown to show how we approach it. So if you think of small, there's mechanical, functional. And we think about small bowel functional obstructions, the one we think about is ileus. And so that's where it falls in like the algorithm. And then the side for large intestine, when we have mechanical and functional, when we have functional large bowel obstructions, we call them Ogilvie syndrome. And so we have similar characteristics between small and large. And this is kind of how we like align it in our heads. So you can see how that affects our decisions later on in terms of management. The last point is about partial versus complete, and I didn't belabor this point, but as you can imagine, the obstructions are on a spectrum from none to like complete obstruction, and anything in between is partial. Partial bowel obstructions are small or large, are usually non-surgical and conservative management, and just usually respond with time, decompression, versus a complete obstruction often will not respond to this conservative management and require surgical intervention. But when we talk about complete obstructions, some of them are surgical emergencies and some of them are not. And so when we talk about large bowel obstructions, that's when there's a complete obstruction, that's more concerning than when we have a complete obstruction in the small intestine. We can temporize that a lot better. So the first one I'll talk about is this mechanical large bowel obstructions. So as I mentioned, causes adhesions, the most common classic one, mass, obstructing cancers. I did include volvulus and some key pictures just to show you guys what it would look like. But other causes, diverticulitis, stricture. This is not a comprehensive list, but hopefully enough that kind of gets your idea of like what we're thinking about. When we talk about volvulus specifically, there's two different types that we get worried about: cecal versus sigmoid volvulus. And so the teaching is that the colon is twisted on its own mesentery through whatever process, and it's twisted in the direction opposite of where it normally is. So if the cecum is in the right lower quadrant, the bowel is now kind of bowing out towards the left upper quadrant. And same thing for the sigmoid, which is generally the left lower quadrant. It's bowing out towards the right upper quadrant. And so there's these like pathognomonic signs, the embryo sign for the cecal volvulus, where it's kind of looks like a fetus, an embryo, versus a sigmoid looks like a coffee bean. You can see a little cleft in here. And then the colon is twisted on itself. The key thing about volvuluses is that they have different managements. Sigmoid volvulus can often be decompressed with a rigid sigmoidoscopy or a colonoscopy, basically detorsing that colon and seeing if the mucosa and the tissue itself is viable, may need to be resected, versus a cecal volvulus will require surgical intervention, usually in the form of resection and ileocecectomy, sometimes also a right hemicolectomy. The key thing with large bowel obstructions is knowing what the ileocecal valve is doing. So what we use the terms competent and incompetent. A competent cecal valve, ileocecal valve, means that it stays and does not allow reflux of contents from the large intestine into the small intestine. When it is competent, it does not allow that to back up. And so if you have a fixed point downstream in the colon and you have a blockage because nothing's refluxing up, that is a closed loop segment, and that's an emergency because that piece of intestine will get swollen, have ischemia, necrosis, and could perforate. Versus if you have the way to decompress into the small intestine with an incompetent ileocecal valve, you can decompress it and use an NG tube and decompress the intestines. And so we'll often look, when we have large bowel obstructions, we'll look at what the small bowel looks like in the caliber. And if it's just only colon, that's more concerning than if it's also dilated colon and small intestine, because that means there's some degree of reflux back. And so it's kind of decompressing itself. And that gives us time, do some conservative management, maybe avoid a surgery if we don't need to. Mechanical large bowel obstructions usually present with abdominal pain. Usually the classic is distension, nausea, vomiting. You can make a diagnosis based off x-ray, as you can see, but often you'll get CT scans as well. As I mentioned, the treatment is usually decompression. So above being an NG tube or an OG tube, PEG tube, if they have it, you can put it to a Foley bag, which is what we call gravity, versus below colonoscopic or rigid sigmoidoscopy to decompress the intestine, detorse it if you need to. Like I mentioned, a scope. You could also put a rectal tube up to decompress the colon. Often surgery will be involved. So even though they're not getting a surgery, will often be called in these cases. Whenever their decompressive process happens, they often need acute resuscitation. Because, as you can imagine, when we kind of detorse and unwind both the veins and arteries, like say for a sigmoid volvulus, there's a lot of waste product that's built up in the ischemic colon that filters out, and then so they get kind of this acute hit of lactate and electrolyte abnormalities, and so they often need fluid resuscitation to make sure they maintain their blood pressures and now reestablish perfusion to their colon. And so, and any sort of bowel obstruction, generally we want to resuscitate them, because if you can imagine anything that's intraluminal, any liquid or food or tube feeds or anything you guys are given, and they're staying inside the intestine, it's not being absorbed by the body, so it's not functional. It's not contributing to their electrolytes, their calories. It's not contributing to their fluid status. And so they probably need some degree of resuscitation, because if you have a couple of liters sitting inside your intestine and you think that the patient's absorbing that, but they're really not, they're already a couple liters behind in terms of their fluid. And then, like I said, often they need surgical intervention to correct the bowel obstructions. When we talk about functional bowel obstructions, the general teaching is about Ogilvie syndrome, which is an acute colonic pseudo-obstruction. It's often found in our sick patients or non-functional, meaning bedbound or paraplegic. Patients have neuromuscular disorders, aganglionic, for example. They have severe electrolyte abnormalities. They've been on narcotics. They haven't really used their intestine for whatever reason. They have no real mechanical obstruction. It's just basically a general slowing down of the intestines. And when the intestines slow down, they have this progressive distension that can happen. It happens both in small and large. When we talk about Ogilvie's, they're not able to pass any stool, but also no gas, so obstipation, no passage of flatus from below. When we make the diagnosis, it's generally based off X-ray, often CT scans, and we'll see, just as this picture shows, very severely dilated colon, and usually the small intestine is preserved. They could also have an ileus on top of Ogilvie's, and that's kind of getting in the weeds of it. But just trying to focus on the colon part, you just see a diffusely dilated colon. The treatment is generally you want to decompress if you're able to, so a rectal tube to evacuate the gas, because if you decrease the intraluminal pressure, the colon function starts to return, because you're not compromising the blood pressure of the blood flow. Because of the intraluminal pressure, you get normalization of like the physiology of how the colon works, and you're getting good blood flow in, correct your electrolyte abnormalities, the function recovers. Ambulating, we say it all the time in terms of surgical patients, but early ambulation is very key if they're able to, like, mechanically, because the moving around actually does help the intestines progress forward. Patients who are bedbound, patients who aren't moving because they're in pain from their surgery, they will slow down their intestines. Like I mentioned, correcting the electrolyte abnormalities, minimizing the narcotics, because that will all slow down the intestines. If they're still not progressing based off conservative measures, then we can consider neostigmine to do a complete decompression of their colon. There is a risk for perforation, so we have to make sure there's no mechanical obstruction, no underlying colon tumor that we're missing or something like that, because you can facilitate a mechanical large bowel obstruction when giving someone neostigmine and they're not completely free, because it'll just migrate a bunch of gas forward and it won't actually empty out, it'll just pop. And then the last case would be for surgery. Patients can have their entire colon taken out. I've done it like once for Ogilvie's, and they have very atonic colon for long periods of time, not responsive to any treatments. You take it out and you give them an ostomy, or you can put them back together, but usually you give them an ostomy, and they actually do very well. They recover all of their functional. They can eat again. Their electrolytes normalize. But it's usually a last line. There's a lot of conservative management before we get to surgery. Think about mechanical small bowel obstruction, same things as for large bowel adhesions. More common we see in hernias, so inguinal hernias, incisional hernias, different locations where internal hernias, bowel gets twisted on itself. As you saw earlier, there's a bunch of small intestine and it kind of wiggles around. It's not held in one space. It's a very large mesentery, but it can flip and turn and whatnot. As I mentioned, other causes, masses, volvuluses, strictures, not comprehensive. Similar presentation as all of our bowel problems: abdominal pain, nausea, vomiting, constipation, obstipation. And this is the kind of progression that we see with most processes related to like the GI system and surgery. So we have distension from stasis for whatever reason, kinking in the intestine, a tumor, it's blocking it, whatnot. And once there's progressive distension, we get venous compromise. We compress the small venules inside the walls. So we get worsening edema in the wall of the tissues that leads to worsening ischemia, because as the tissue gets more edematous, there's less, it gets physically bigger, and then you get further and further away from your actual blood supply. We get mucosal ischemia, which is, that's the furthest part from the actual blood supply because it comes from the outside in. And so if we have tissue that's already getting more and more edematous and the wall is getting thicker, it's harder for the actual arterial blood flow to get to the mucosa. Once you have mucosal ischemia and breakdown, then you get bacterial translocation, and then that leads to worsening pressures, worsening illness, hypoperfusion, worsening ischemia. And then once you get to ischemia, you get necrosis and perforation. So this sort of spectrum is kind of where all these disease processes fall along. And we're trying to, decompress them or address them before it gets to the perforation stage. Sometimes patients just show up like this, but sometimes it's just distension. And it's like a matter of like, are they going to progress this way or not? And depending on their etiology, they're more likely or not. When we're making diagnosis for small bowel obstruction, yes, we'll see it on x-rays, but more often than not, we want CTs with IV contrast. Ideally, I understand we have patients who have renal failure and it's not ideal, but we, on the surgical side, would prefer it to see what the perfusion is like to the intestine, because it shows us which intestine has that ischemia, that compromise, that haziness that we see on CT scan that doesn't look normal. And then plus or minus PO contrast. And it's a case-by-case situation depending on what the etiology is. I would just say if you're considering it, it doesn't hurt just to call and ask, like, would one be helpful more than another if you're not really sure, or if you just want to pull the trigger and get it. Just make sure the patient's safe enough to take in PO contrast or not actively vomiting. You can give it down an NG tube if they're not having a ton of bilious output, but if they're having, I would say, greater than like 500 to a liter of NG tube output, I would not encourage PO contrast, because they're probably going to reflux it up. They're not going to move things forward, and you don't want them to aspirate on it. Treatments, like I mentioned, NG tube decompression. The idea is that it's like controlled vomiting. We basically get only the contents that are in the stomach. We don't put it into the small intestine, because we'll often cause mucosal damage to the intestine, because you can't be constantly sucking down on it. But for the stomach, it's actually very forgiving. But we'll decompress. I would recommend low continuous suction. The tubes that we have that are modern day have that blue sump port. So basically air can suck in and it will not cause the mucosal injuries that you see from putting it to continuous suction back in the day when we didn't have that sump port. And so I know people here have their own practice patterns, and this hospital has a lot of intermittent suction, but there's no legitimate reason to do that. And so I would just recommend low continuous suction. Otherwise, you're just stenting your GE junction open with a tube, increasing the chances for them to throw up and aspirate. Fluid resuscitation. So if you're, like I mentioned, you have all this intestinal volume that you're removing, the body's not absorbing that, they're going to need fluid resuscitation, electrolyte correction, and then surgical evaluation. We usually like to do if we decompress the intestines, we'll do a gastrographin trial. Basically, you have gastrographin down the NG tube and take serial x-rays and see how long it takes to get to the colon. If it doesn't arrive at the colon within 24 hours, that to us is concerning, that there's a low chance the mechanical bowel obstruction will resolve on its own, in which case they'll need surgery. But again, if you have a complete mechanical bowel obstruction because you have a tumor completely occluding it or crushed by a tumor, that problem is not going to get better no matter how much decompression you do. And so it may need surgery sooner rather than later. It just depends on the etiology, but that's generally how we would approach it. And then last is functional small bowel obstruction. So this is the ileus that a lot of patients get. It's a paralytic ileus, meaning a general slowing down of the intestines. The causes, the most common reason is patients get intra-abdominal surgery. We compress, we squish the intestine, we move it out of the way, we insufflate air and it compresses it, and it doesn't like that. It doesn't like being exposed, doesn't like being touched, doesn't like being pushed around. Other issues were deranged electrolytes causing functional, like the cells do not work, and so they dilate. And then the progression starts. Pain medication, slowing down the intestines. It happens globally. It's not just like the colon, the small intestine, as well as the stomach. Any sort of traumatic injury, head bleeds, etc. And then anesthesia. If they get an anesthesia for another procedure, gentle sedation for whatever, all this has impact on the intestines if they're not active. I mean, there's a lot of lists, a lot of things that can cause ileus. but it's very vague. Like I said, it presents like a mechanical obstruction, but there's no actual functional blockage. Similar diagnosis as for mechanical abdominal x-rays or CT scans. The treatment's generally supportive, so it's that decompression, electrolytes, minimize narcotics, ambulate, whatnot. But the most important thing is to treat the underlying problem, because the problem is not necessarily the intestines are slowly down themselves, it's like what's causing it. And you need to figure that out. Is it just related to us doing a surgery 2 days ago, in which case this is not unexpected and they threw up and we put an NG tube down and they're going to recover? Are they having an infection going on, a deep space infection? Are they leaking? Are they getting too much narcotic and it's just totally zonked them out and zonked out their intestines? Or is there K like 2 and we're not correcting it? And so you kind of have to do the workup, but realizing that the problem itself is not that the bowel is dilated. There's no one specific drug or motility agent that works really well. Newer sort of protocols require like amend or restore, specifically for chronic narcotic patients or patients who are on like ERAS pathways. They'll get this either before or after surgery. It's actually more beneficial if they get it before surgery and continue it afterwards. It's supposed to be part of their early recovery after surgery pathways that you guys may see. But those are not best. They don't fully prevent it, nor do they treat it. It just helps kind of curb some of the narcotic effects that can happen, that can contribute to it. And it's usually, not just one factor that contributes to ileus. They have many different reasons. They're an X-lapse, so we got inside their belly, their lights are all messed up because they're a dialysis patient, and they're not walking around. All these have some degree of contribution. And the one thing to keep in mind is if they have a prolonged ileus, and really for any of these problems, if you're concerned that they're not going to absorb or they're not going to be able to eat and maintain the nutrition significantly, that you should consider TPN. Usually we do it about day 5 or 7 if they've not had any good nutrition, because we're worried about either the surgery, stuff falling apart inside, or their overall progression. If we can't, get them to heal their wounds and they eviscerate, then they have to go back to the OR, it's another hit, so on and so forth. We talk about ischemia. We'll talk about acute versus chronic ischemia, and again, small versus large bowel ischemia. When we mention small, we call it mesenteric ischemia versus large is colonic ischemia. And then NOMI is non-occlusive mesenteric ischemia, and we'll talk about that as well as another a flavor of it. So acute mesenteric ischemia usually caused more often than not by an acute embolus from the heart, causing a acute obstruction at a proximal branch of the SMA. So you can see how it's literally coming down and it just pitters off. There's no more contrast flowing through. And that goes back again to the anatomy before, where it's not like distal obstructions really cause problems. The bowel can work around that. It's when it's proximal, and it's usually right at the takeoff of these arteries because they're just so perpendicular. These are nitises for where the clots will stick. The other less common but also existing cause is thrombosis from a ruptured plaque. So patients who have had calcifications and for whatever reason, blood pressure out of control, they got hit by handlebars or whatever, that plaque ruptures and acute thrombosis. If they haven't had time to form collaterals, they will get the acute mesenteric ischemia. The classic teaching is acute abdominal pain out of proportion to exam. They often have peritonitis. So they're screaming out in pain, but you can push on their belly and it's nice and soft. And it's because the intestines are just dying on the inside, but they haven't fully perforated. When they perforate, that's when you get the peritonitis, and that's usually late game. Diagnosis is CTA, as you can see, and we'll usually look at like axial, sagittal views to take a look and see like, okay, here's blood flow. Okay, there's no more blood flow. Sometimes you'll get distal reconstitution of the blood vessels from some degree of distal collateral flow. Again, it's not reliable, especially in vasculopaths who have had narrowing of their arteries for long periods of time. Their body will make new blood vessels, and so they might have a way to get around it, but it may not be enough to supply the actual intestine. So if it's like knocking out the main pipe feeding the intestines, that will cause the acute symptoms. The treatment for this is generally surgical, considered an emergency. Depending on the etiologies, it's a combination of general surgery and vascular surgery. Vascular surgery will either go down endovascularly, take out the tumor, the blood clot, thrombectomy or suction thrombectomy, or like break it down. There's all the different techniques they have. They can do catheter-directed thrombolysis, which is just feeding like TPA directly into it to see if they can bust up that clot. And then we, as part of the general surgery side, need to do some degree of bowel evaluation, whether it be doing an exploratory laparotomy and cutting them open to take a look and see what the intestine looks like, or a diagnostic laparoscopy, making small incisions, depending on patient stability and what they're able to tolerate. And again, we're looking to see, is this going to recover or not? Because they could remove the thrombus, but if the patient has had occluded intestines for like 10 hours, there's a good chance all of it's going to be necrotic and black, and it's not going to recover. And you can't live without small intestine. And so that's where kind of our two halves of the same problem come in terms of co-management. When it's thrombosis, they'll talk about stenting across the thrombosis and possible bypass, and then also evaluating the intestines. And often we'll take them for surgery and we'll see that it's likely just threatened, and we'll leave them open. We'll let the bowel reperfuse and then go back in a day or two and see what it looks like. Because sometimes the initial insult is you can't make a clinical decision on if you're going to resect bowel or not, because it could recover, it could survive and become healthy, or it will demarcate and tell you that it's dead. And so we'll take a look and basically take out anything that's floridly necrotic and dead, even perforated. But if it's questionable, we'll try to leave it, because we want to leave as much intestine as possible. And then we'll go back in a day or two, take a look at it and see what's viable or not, and put the patients generally back together. We talk about chronic mesenteric ischemia. The general, like I mentioned earlier, is like progressive atherosclerosis. You see them at usually the takeoff of the blood vessels. So this is the SMA, and you see extensive calcifications causing progressive narrowing and less inflow into the big arcades. And so generally what happens is patients get they get angiogenesis, have collaterals form, and they can feed their intestines with other sources of blood. But it's not, you never know where they are in that spectrum. You can even look and see if there's collaterals that have formed. They may exist, but they might not be enough to feed the entire demand of the intestines. So they often present with vague pain. Sometimes it's after eating, especially if they have critical enough calcification. But again, it's very vague symptoms. You'll get imaging in the form of a CTA and take a look and see what the burden is. And then the treatment, depending on where they are, if they're, this is not like an emergency usually, because chronic mesenteric ischemia, you can temporize, you can give them TPN, you can give them tube feeds of a smaller volume but good calories, and nutritionally optimize them if you need to fix other problems that are heart and kidneys, lungs, whatever, and then come in and get an elective surgery in the form of a bypass or a stent. And then we'll also evaluate the bowel and make sure that it's viable. Generally, we are not called for like these elective cases. Now, if it's acute, we'll definitely get called. But sometimes we'll get called in the OR from vascular surgeon. It's like, hey, can you take a look at the bowel? We've been working on this anastomosis for like 6 hours, and we're just concerned we've occluded, the intestinal flow for a period of time, and then we'll get called in. But just making sure that after they do all their work, that they still have good flow to the intestines. And then non-occlusive mesenteric ischemia, it's strictly related to hypoperfusion, diagnosed in the same way as all the other mesenteric ischemias. But the treatment is usually not surgical. It's usually supportive care, because the etiology is some trigger outside of the actual process of the intestines. And so, as you can see in this diagram, there's like low cardiac output, hypovolemia, cardiac surgery, cardiac arrest, septic shock, and hemodialysis. So different things that cause a malperfusion to all of the intestines. So not just one focal artery or one branch of one artery, but a global phenomenon. And we get a lot of call about these from the cardiac ICU, because they're concerned about the intestines because they have an elevated lactate. And we'll say, well, you have a global hypoperfusion. We see it on your CT. We can see it on your labs because you got a lactate, but also your LFTs are high. So you're not having good flow to your liver as well as your intestines. And then we get to this argument of like, where do we do our surgical intervention? And we're trying to optimize it, because there's no good way for us to know what the actual bowel viability is. It's kind of like Schrodinger's cat. You don't know until you look at it. So we could do these invasive X laps and diagnostic laps on these like critically ill, cardiac surgery patients, but sometimes it's negative. And then now we just have to deal with all the complications of a big wound. They could dehisce, they could eviscerate. The bowel could be very dematous and it may not actually close, in which case they get a massive hernia, and that becomes a problem down the line. And so we want to intervene at the right time that we can actually be helpful. But we're always worried that we might come in too early, and then it's all looks normal, and we leave them open, and then we go back a couple of days later to close it. But oh wait, we can't, and then we have those problems. Versus too late, like everything is just too dead. And sometimes we do get called like at the 11th hour and be like, hey, can you take a look? And we just open it, it's all black. And so no one's really figured out like an optimal time to figure out to go in and intervene. And it's usually like our sickest patients that have this phenomenon, as you mentioned, as you can understand, because of the triggering causes. that they are sick, they need help, but we may not be the people to help them. But if we don't help them, they may progress into a place where we cannot help them at all. So that's kind of what's going through our mind when we get called about these cases. It's a different flavor in talking about, we talk about arterial ischemia and all the arterial system problems. There is a venous component as well. We can have mesenteric venous thrombosis, clotting of the veins that decompress the intestine, whether it be the SMV or the IMV. IMV drains more of our distal colon, and SMV basically drains everything else. So all the transverse, proximal colon, and then all the small intestine. And so if we get acute thrombosis of these vessels, either from hypercoagulable state, a prothrombotic state, classic is like trauma, some intra-abdominal necrotizing pancreatitis, tumor perforation, leak, abscess, whatever have you, and they get acute clot that develops within these vessels. As you can imagine, if you have a clot here, there's no drainage, back pressure builds up, and it's the same sort of etiology as what we had before. They present with this abdominal pain. It could be acute onset abdominal pain versus just chronic progressive abdominal pain, depending on what the cause is. If there's liver etiology and they get portal vein clot and then it's kind of working its way backwards, that's different than if it's just an acute SMV or IMV thrombosis. Diagnosis is usually a CT scan. We'll ask for the venous phases. And then the treatment generally is supportive. We want to anticoagulate these patients as soon as we can. And then IR can do interventions where they do declots or thrombectomies through the portal vein system, access the liver, come through the portal vein, and declot SMV or IMV as appropriate. But if they're presenting with such acute abdominal pain and horrible labs, we often will take them to surgery. And they often require a significant amount of bowel resection because you can imagine the arterial drainage had a ton of arcades. There's a lot less on the venous side. It's not as reliable as the arterial side is as well. And so we do have to do a lot of bowel resection. And so, like, for example, we have a 27-year-old lady with some autoimmune condition who presented with acute SMV thrombosis, and she has maybe 150 centimeters left of small intestine. These are the patients that we usually talk about that are like heading towards a small bowel transplant option because they lose so much small intestine so quickly that they need to figure out a new way of getting it. Otherwise, they're going to live a short gut, and that's not a great lifestyle with like TPN, NPO, and that sort of route. And so this is the patient population that we do get worried about if they have acute mesenteric venous thrombosis with abdominal compromise, that they're going to lose a lot of intestine, and then have an ostomy, managing that, all that stuff. A couple more things, just ischemic colitis, which will also get called for pretty often. The cause is hypotension, as you can imagine, blood flow coming from the outside in. If you have low blood pressures, it's not perfusing all the way to the mucosa. And then as a result, the mucosa has all these compromises where it becomes pale, frankly, like necrotic, back here black. This is kind of like a worsening ischemia. This is some edematous tissue. And this is probably like the best you're going to see here of like normal, close to normal colon. But all this is kind of compromised, and the mucosa starts to slough off. It happens basically at watershed areas where two arteries that are feeding overlap. And so common places are the flexures, the splenic flexure, and the rectosigmoid junction. Rectosigmoid junction specifically because it goes from the visceral blood vessels, the IMA feeding the colon, to your branches off your iliac arteries or your pelvic vessels. So if you have a pelvic tumor and whatnot, kind of changes your approach to it, because there's two different blood supplies to that point. The presentation, because of the mucosal ischemia, is you get bloody diarrhea. The treatment is generally colonoscopy. We'll ask you guys to take a look and see what they see, because it does matter if it's a focal process versus a diffuse process. And sometimes they can localize like which part of the colon is affected. Sometimes CT scans with IV contrast to see where the blood flow is going. Generally, we recommend supportive care because if it's just mucosal ischemia, then we can tolerate it as long as it's not transmural. But if it is transmural black, then they often require surgical resection. But we appreciate the help of like the imaging studies and the colonoscopy to help us locate, because we don't know. We're not going to open up the colon and take a look and be like, oh, this part is viable, close it back up, because that's all points of weakness that will perforate and will leak. And so we need to have localizing studies to help us figure out which part of the colon to take out. And then the last thing is pneumatosis intestinalis. So you guys will also see this sometimes on CT scans. and it's basically gas in the wall of the intestine. We often see gas in the intestine as patients are supine more often than not when they're getting their CT scans. Sometimes they get them prone, but supine. You'll see air kind of rise, right? But if you see air in dependent portions, so on the posterior aspect of the intestine, that's kind of concerning that there could be a degree of pneumatosis. And then you have to figure out where did that come from. And similar to an ileus, it's not a disease itself, but it's a clinical sign. And then you have to figure out, like I said, what's causing it. It could be benign. Most common reason is if stuff gets acutely too over distended. So if a patient has a gastric outlet obstruction and they get too much tube feeds or whatever, and they don't throw it up, all that intraluminal pressure will do that progression that I mentioned earlier. And then you start getting air in the wall of the stomach, and you're like, where did that come from? But if you decompress it and give them antibiotics in time, they actually do recover very well. Similar processes can happen in the colon, in the small intestine. All these require, like, you'll call us to weigh in and see if they need surgery or whatnot. But more often than not, it's just decompression in time and supportive measures. The pathophysiology, there's a couple of different thoughts as to why this happens. The first one's the mechanical breakdown, the one I mentioned earlier about the mucosal ischemia, bacterial translocation. There is a thought about gas that tracks from the mediastinum down into the retroperitoneum and then into the mesentery of the vessel. So if there's like a pneumothorax or mediastinitis, like air in the mediastinum, and then that tracks along the aorta and then comes up the aorta, the blood vessels, and then goes into the wall of the intestine. That could be a source, much more rare. And then gas-producing bacteria. So all the bacteria that are inside our stomach, inside of our intestines that are limited to that, once they get access to this new plane, they start producing gas there. And that's why we generally give antibiotics for patients who have pneumatosis. Like I mentioned, diagnosis, X-ray versus CT, more often a CT, and then it's supportive measures, but sometimes they do need surgery, especially patients who are in extremis. We will talk about taking out whatever part of small intestine, colon is affected. If it's stomach, generally we try to leave it in and decompress. The stomach is very forgiving with a lot of collateral blood supply, but it's a case-by-case situation. But that's generally how we approach it. This is the question I was supposed to include, so I don't know if anyone wants to answer it. Look, I don't want to be doing this either. I just do what I'm told.
One.
All right, sounds good. Mesenteric ischemia compared to the other causes, it's most likely an embolus, but I did mention ruptured plaque. But when we think of acute embolus, that's what we think of. And there's my contact information. Feel free to email or text me if you need something. And then that's all I have. So I'm happy to answer any of the questions, like any surgical potpourri, anything, clarify for you guys from our perspective.
Thanks so much. This was really, really helpful and really informative. I don't know if I might have missed this, but is there a role for, before getting a CTA in somebody with chronic mesenteric ischemia, is there a role for ultrasound, in somebody that's not, acutely ill, or really it's just we start with a CTA?
I would say there's a study that's available to order, a mesenteric duplex. It has some technical limitations in terms of like the bowel gas patterns. They can't always visualize the intestines, and you have to pick the right patient. I think if you want a definitive answer, then the CTA would be a lot better. It's not like it's an invasive study, so you can get it. I would just say it's not as useful sometimes. But you brought up a very good point, is that and it kind of goes back to like what I talked about earlier about CTs, that they show that there's blood flow in some pattern to whatever we're evaluating, but it doesn't tell us anything about flow, like rate of flow and whatnot. And so if we're concerned about that, then we can pursue it down the ultrasound route. But I would say if you're just looking to see, is there flow to A, B, or C, get a CTA, prove that. And if there's not, then you have your answer. And if you do have flow, but having issues with, like, after they eat, they get postprandial pain or something like that, then maybe that's the route we kind of work them up and go that way.
Got it. And then for the neostigmine, so patients that get neostigmine, these patients have to usually go to the ICU just for closer monitoring. It's for, just to like refresh my memory, it's for the risk of perf, and then also bradycardia, I believe. Is that why we send them to the NICU sometimes for these?
I mean, in residency, we would send them to like basically a monitored bed, but I guess the policy here is ICU, but somewhere to be monitored. If one's ever given it, you have to give it like over 10 minutes. And you,
Oh.
you basically sit there and you just like infuse. It's like I think it's like 10 cc's or something like that, and you're just slowly infusing it. You're exactly right. You're watching for the reflex bradycardia that can happen. So just have when you order and you're gonna do neostigmine, just have
Yeah.
atropine order for bedside too.
Wow.
Yeah,
Scary.
just slow
Okay.
it because it really the effect of bradycardia is seen when you give a lot of it very quickly.
Got
And
it.
so the recommendation is to give it slow, but some people don't like to wait, and then they give it
Yeah.
fast, and then they have that. But you're
Wow.
exactly right with all that.
Oh, thank you.
Dr. Fung?
Sorry, I was muted. Okay. Great talk. Thank you so much. So I'm a palliative care provider, and I regularly have patients that are in the North Cancer Center that have partial bowel obstruction or full bowel obstruction, and we're calling general surgery and other services to figure out what to do. And I feel, and then many of these patients will have partial bowel obstruction. Sorry, I will have peritoneal carcinomatosis, and I just feel as if I've never seen general surgery want to come in in those cases, so I don't know if there's value ever calling you guys. But I just wanted to get your opinion. Like, is there circumstances where you will intervene when patients have carcinomatosis, or will you? Or is that just a no-go for all cases?
So I don't think it's a no-go for all cases. We're happy to see them and whatnot. I just don't think our interventions are going to be as productive because if we do, let's say we come in, we operate, and they have a cancer, we take out the perforated cancer or whatever, and we put them back together, or we give them an ostomy, depending on where it is. If it's not distal enough, they're going to have so much GI losses that you're going to have a hard time managing their fluids and their electrolytes. That's one problem. Or if you put them back together and close them up, things we worry about is that anastomosis is falling apart as it sits inside peritoneal carcinomatosis, the malignant ascites. Their overall like nutritional status is generally poor compared to like the lay population. And so they could have a horrible leak, in which case us going back in and putting them back together again or trying again is not going to be productive, and they end up with an ostomy, which most people don't want. And then things we worry about when we cut into patients is like the exploratory laparotomy. If they don't heal and their fascia falls apart, they could eviscerate, and that requires another surgical intervention. So it's not that we don't like. We could technically do this to solve the problem, but is it going to help the patient? Because we're not in the business of expediting people's deaths, and I think dying from a leak sounds way more morbid and painful than a palliative peg tube. There are there's data on like bypasses, like small bowel bypasses around like pelvic tumors and whatnot. It's not great, and those cases are always tough because we're still taking on those risks of the anastomosis and everything falling apart. It's a matter of a discussion with the patient and seeing what they're willing to tolerate, because we go in and we can't mobilize. We have a person right now in the ICU who has stage 4 bladder cancer, had a large bowel obstruction, perforated, and we took out his right colon, and we couldn't mobilize his small intestine to bring up an endostomy. So he's got a loop ostomy and a mucus fistula and a drain, and he's like miserable. And we're like, yeah, we didn't know what we were getting into, but we had to go because you had acute perforation. You were going to die otherwise. And so I think it's the discussion. And honestly, if people are not coming in, that's a problem. And please let me or my boss, Dr. Damon Clark, know, and we can address that. But we are happy to have that conversation with the patient. And I think some informed care from us and them, and be like, this is what we're seeing. This is what we're thinking. This is what it could be. This is also on the spectrum. Are you okay with that? Because and my experience is being consulted on NORS patients, going there and explaining why I'm not rushing in to operate, or why we're trialing this, or why we're not offering surgery. They're understanding, and they just want to have a conversation with someone who's going to be doing it. So that's the way I would approach it. And I'm sorry you've had bad experiences before.
No, it wasn't a bad experience. I just wanted to make sure we weren't wasting your time. It sounds like you want to be part of the discussion, and it is that discussion, whether that's with the other clinical teams or with the patient. That's really helpful.
Yeah, just we'll be part of the discussion. I mean, there's a lot of times I will say it's easier for me to just say yes to do surgery, because then everyone like, okay, cool, surgery's doing surgery. We don't have to worry about things anymore. I have a lot more conversations and time spent telling people I don't want to operate and here's why. But if I have a good reason, I'll make sure it's key, because otherwise taking like unnecessary risks to harm a patient without any real productive benefit, we're not in the business for that. So
thanks, that's very helpful.
Dr. Angar?
Hi. So that was a great talk. Thank you so much for coming to speak to us. I had a specific question on your slide where it sort of talked about the sort of differing, diagnostic certainty and clinical signs in mesenteric ischemia. Particularly, I think my experience is, in the cardiac surgery patient. I'm wondering, as a floor team, are there any clinical signs, any specific things we can be looking for to try and make that diagnosis a little bit earlier in the course, and any major differentiating things other than sort of blood from an infectious diarrhea or something more benign?
Yeah, so I think it's tough because there's no like one magic test. It's not like, you test your urine and you get a UTI sort of thing. I think you have to do multifactorial evaluation. I would first, global vital signs, and just making sure that the blood pressure is fine, because it's the etiology of their hypotension that will drive it. So if it's cardiac dysfunction and they have cardiac dysfunction, they were weaned off epi yesterday, they might need to be back on epi because they're not pumping forward. Early signs, people talk about getting labs, the lactate, the LFTs, and your BMP and CBC basic stuff. But lactate's very non-specific, and especially if you have liver dysfunction, we cannot adequately say that it's not just liver, and we don't know if it's bowel, liver, both. So it's kind of very vague. We get consulted all the time by cardiac surgery for elevated lactates, and it's like I don't know what to do with that information. It's not specific. I would say if they're stable, then doing a faster workup is probably better, because often the problem we run into is when they get sicker and sicker, they're too unstable for transport, and so they cannot get imaging. And I think that's kind of where the threshold is. And then we're getting to the point where like they're too sick to do a study on, therefore we're just going to take the surgery and cut them open to see. And I think if we can maybe do it a little bit earlier and maybe aggressive, figuring out if they need to travel somewhere, whether it be to get a swan from the cath lab, or to do this, or like whatever, that we kind of do it a little bit sooner rather than kind of waiting and doing it stepwise, because they might not have the window later on. So that'd be the only difference. But I think having a high suspicion, patients, abdominal pain, whether it be like progressive worsening, not getting better with like decompression, nausea, vomiting, it's all of a sudden kind of starting and you're seeing it progress, is probably the biggest thing. But yeah, sorry, I don't really have a magic test for that.
I mean, that's okay. Thank you for the time.
Any other questions from the crowd? While we wait a little bit, thank you so much again, Dr. Patel. Elena has posted like the CME credit in the chat, and as well as how you can get the MOC credit with today's talk. So just email her with the answer, which is 1, and then you can get the credit for that. I'm not sure. I do have a question. I'm not sure if I missed it in your earlier talk because I was kind of a little bit all over the place. But for like the management of ileus, I feel like there's always like differing opinions on how to do so.
In what regards?
In terms of just like conservative management with medications, like are you supposed to move the bowel or are you not supposed to move the bowel? Because I feel like different surgical teams kind of do different things.
Oh, and can I add on to that question? I think you mentioned there isn't much of a role for intermittent suction. So related question is just like why does that exist and when would you use that?
Thanks, Dr. Burrell. I think your question is a little bit easier, so I'll answer that first, and then I'll go back, Dr. Ng, to yours. So when our modern day NG tubes, I guess let me go back in time. Back in the day, they just had one single lumen that went down into the intestine. And so if you suck down continuously, you would cause mucosal ischemia in the stomach. And so they came up with the setting of low intermittent suction, which basically like you suck down and then it releases it for like, I don't know, 10 seconds or 30 seconds or whatever. And then it restarts it. Modern day tubes have a lumen that goes straight down into the intestine, but they also have like a blue little side port. And that is another lumen that goes all the way down to the tip. And the idea is that is sucking in air from the outside world and preventing the stomach from fully closing down around the tube because there's an air pocket. And so as a result, you can put it on continuous suction and it'll just suck in air from the outside world into it to prevent the stomach from fully collapsing and down around the tube. And so that goes back to what I said earlier about when we stent the GE junction open by putting a tube straight down, it just opens up that muscle. If you're not actively sucking, it's basically like a super highway for people to throw up because you just lower the pressure because you open up the ring. And so my thought would be, if you have these tubes that do this function on low continuous, just put them on low continuous. I will tell you, and you guys will be very frustrated, that every surgeon here has their own opinion on this and how they want it done, and colorectal will manage different than hepatobiliary, and then even ACS, different. My partners and I don't agree on this. All I can say is that if there's multiple ways of doing things, there's no one right way. But I think my approach of minimizing the risk for aspiration is probably the most reasonable. But I'm sure if someone else gave you a lecture from another department, I'm sure they would say something different. So that was for you, Dr. Burrell. And then Dr. Ding, I'm sorry, just like the differences in the management, right? I think it's tough because we don't know which component is contributing most to a patient's ileus. We never know if it's 40% electrolytes, 10% narcotics, and 50% because they're not walking around. So we'll try to give you broad recommendations. Often some of the decision points were, okay, if you have dilated intestines, great. If you don't have any stomach dilation, a lot of people won't put in an NG tube. And I think that's not unreasonable because you're not spitting enough back up into your intestines, from your intestines into your stomach that you're going to throw it up, because we're just trying to prevent that aspiration event that could happen. That's all we're doing with that NG tube. So people may differ in that way. People are very particular in their narcotic regimens and like what they allow their patients to have post-op. And so some people put them on standing narcotics and I think that's crazy. And some people don't. And so they kind of have to roll with whatever sequelae of their decisions are. I think the thing you want to do is decompress the intestines in whatever way to get them to move either backwards or forwards. Because if you can imagine, when we're like managing bowel obstructions, if we stuck out a bunch of stuff from the stomach and it's bilious, that's all stuff that's refluxed up from the intestines because we don't have bile in our stomach normally, right? So it shouldn't be there. When that becomes clear, that generally tells us stuff is starting to move forward because stuff isn't refluxing up from the duodenum into the stomach. And that means there's a pressure gradient. It's kind of returning back to normal. Its peristalsis is returning back to normal. There's a high suspicion that it's resolving. That plus clinical signs that they start passing some gas. And then even having a bowel movement, stuff is trying to move forward. We're fine with it moving forward. That's the ultimate end game. It's not like it's always just going to stay there. But we need to get it out so that it can recover, because it's a matter of like stretch. If you stretch the intestine too much, it cannot contract down and do its job. So we decompress it by having it spit stuff back into the stomach, and then it gets smaller, it spits more, it gets smaller, to the point where its caliber is back to a normal functional size. As the tissue edema improves, as its perfusion improves, it starts to peristalsis, and it's going to want to push things forward naturally. That's just how the intestines work. And so we're trying to get it back to that normal state as soon as we can. It's just a matter of like how aggressive, I guess, people want to be about it. And I wish we were all more consistent about it. But like I said, different teams will manage it, different degrees of aggression, whether it be from their training or from their experience or just. So I'm sorry, again, I don't have like a
No, I think it's more like, I think I've seen at least I don't do too much like spine co-management per se, but like for the spine patients, I see them being very aggressive with the bowel regimen. Like when they have an ileus, they're going like full on up from above and from below to like get some motility. And then I move on to a different surgical service, and where like it's kind of like, oh, don't do anything, like don't give them anything, kind of wait for the bowel to come back. And so it's just a little bit confusing which way to go.
Yeah, part of it's like if they operated in the abdomen or on the intestines or push them around, that's one thing that does change things, especially if they have a new connection. We don't want to introduce new stuff. So like for our surgical patients, we won't want to introduce anything because we want the anastomosis to heal as much as possible before we start introducing things. So we want to test the system and cause a leak rather than just letting it heal and then proving to us that it works. Now, I don't think that spine necessarily does it right by like hitting them from above and below. I mean, if you look at the regimen, it's ridiculous. Like in terms of like their bowel regimen, it's way too aggressive and it's non-functional because like no one needs a BID suppository, yet here we are. And we take care of them in the ICU and we just kind of like give up because it doesn't make any sense. because there's no magic drug that's going to make the intestines work. It's the minimization of narcotics, the early ambulation, which they don't let us do because they're spine and keep them flat for 2 years. Like all this stuff that kind of contributes. And they're like, well, we're going to take this off the table by introducing a ridiculous bowel regimen. But if you don't have, like, we can talk more about these medications, but like if you don't have a gas in your colon, like, and the colon's dilated, there's really no benefit to giving you a suppository. It's not going to, what is it going to expel? There's nothing to really expel. If you don't have a lot of like hard stool inside your rectum and like sigmoid colon, then enema is not going to be productive. But if you order it, like you just like, A, never get a phone call about it, so you don't have to hear about it. And B, you're just assaulting them for really no real gain. I will say my general thought is that we let the intestines recover, completely decompress as much as we can. They're pretty aggressive about it here. They'll do gastrographin very early, especially in our bowel obstructions, but it'll be, 4 to 6 hours of decompression, and then immediately do these studies to see if they're going to pass things through. If we know that they're going to have a prolonged ileus, then we'll decompress, wait for the output to drop down at least 24 hours, let it drop down to like a lower level, less than 1,000. About 500 is okay. And looking at the quality of it before we start introducing new things. I don't like to introduce like bowel regimens and patients have NG tubes in, because it's kind of like, what are we doing here? But if you're feeding through an NG tube, that's a different story. But let the intestines get the optimal time to recover, and then slowly start introducing things to keep the bowels lubricated. Because it's not like any magic medication. Senecolus is not going to fix ileus. It just helps make it easier to have a bowel movement. But if they've had pelvic surgery and pelvic floor and you don't want them to strain, then you want them to make sure they have their first bowel movements nice and soft and loose. You don't want them to like push out a rock and disrupt your anastomosis. So it's unfortunately very variable, and maybe just questioning why they're exactly doing what they're doing, other than like, well, we want to prevent an ileus, because there's not like a pathway to prevent ileus. You do the housekeeping things to minimize the risk for having it, but there's no like magic recipe. Every patient has a different composition for reasons why they would have it. So being aggressive doesn't mean that you're better at managing it. You're just probably not even treating anything, to be honest.
Thank you. And just really quickly for like Ogilvy's, when is when you're looking at like imaging and all that, like when do you get really concerned in terms of how big it is? Is it like more than 10 centimeters is when like you're more concerned?
So it actually depends on where in the colon and rectum the dilation is, like how much the dilation is, because it's related to wall tension, and like the transverse colon is much more floppy, and so you can actually tolerate more there than if you can do with the cecum, because it's fixed in the right lower quadrant. That, because it's like stuck against the back wall, it can only tolerate about 8 to 10 centimeters versus like 10 to 12. For like the transverse colon. But somewhere in that range, if you're getting up to like 8, I would definitely have a surgical team weigh in regardless and just make sure things are going okay. And if it's a focal problem, that's a little bit more concerning than if it's just a diffuse, which is more likely what Ogilvy's is. And then I think, just checking labs, like making sure, like, we have this acute finding on imaging correlated with labs. They have a white count, elevated lactate, and some electrolyte abnormalities. More concerning that this is going to become a real big problem, because you're having malperfusion to their intestines. I mean, it could be that the colon is super dilated in Ogilvy's, and it's not the colon is being hyperperfused, but it's the other intestines that are being squished by the colon that, secondarily are being hyperperfused. So it's not just the organ itself being involved, but like its neighbors too. So just doing a little bit of workup. But that, I would say, if you're like at 8, just having a team weigh in and making sure, like, hey, is things going right? And we'll probably be like, yeah, no, everything looks fine, and then just do supportive measures. But if it keeps progressing and progressing and progressing, and if things aren't being corrected, there's for some reason electrolytes or whatever, then it's a different discussion.
Gotcha. Thank you so much. We are at the hour. I just want to see if there's any last minute questions from the group. Okay. Again, really, really appreciate this talk. Thank you so much for coming on.